Hello and welcome to the Business Talk podcast. I'm your host Deepak. Let us extend a warm welcome to Professor Mario Macis as he joins us on our podcast. Professor Mario Macis is a professor of economics at Johns Hopkins Carey Business School and core faculty at the Hopkins Business of Health Initiative. He is also affiliated with the JHU Berman Institute of Bioethics, National Bureau of Economic Research, and Institute of Labor Economics. Professor Macis' work contributes to the field of health, labor development, market design, and managerial economics. Prior to joining Carey, he was a faculty member at the University of Michigan Ross School of Business. He received his PhD in economics from the University of Chicago Department of Economics. Professor Macis has been consultant for the World Bank, the International Labour Organization, the National Marrow Donor Program, the United Nations Development Program, and the World Health Organization. He also served in a National Academies of Science, Engineering, and Medicine Committee. In this episode, Professor Mario Macis will share valuable insights from his research, the role of trust in healthcare seeking behavior, insights, and implications. Professor Mario, it is truly a pleasure to have you with us today.
Deepak, thank you very much for the invitation. It's an honor for me to be part of your podcast series. A very interesting set of speakers that you've had in the past, and thank you also for the very kind introduction.
Thank you, Professor. Professor, what motivated you to explore the role of trust in healthcare seeking behavior, and why is it such a critical yet understudied topic in health economics?
That's a great question. So the background, behind this specific study, which has now expanded to multiple studies to a research agenda, is that my co-author and I, Michael Darden, who's a colleague in the Carey Business School, we were attending a retreat of the Hopkins Business of Health Initiative. We were discussing gaps in the health economics literature, gaps that could affect our understanding of how people approach the healthcare system, how people relate themselves to the healthcare systems, and people's propensity to undergo preventive care. Annual checkups, but also vaccination. We were just coming out of the COVID-19 pandemic when we were having these discussions. And of course, a very prominent fact was the hesitancy by many people to receive the COVID-19 vaccine. And just by listening to people, reading the news, we immediately got the sense that there was a mistrust in healthcare institutions by a good share of the public. We realized that there was a gap in the health economics literature in terms of understanding the extent of this mistrust and the reasons behind it. Other disciplines like public health and medicine, they have explored patients' trust, typically in healthcare providers, physicians, nurses. But we realized that there was this big gap in the health economics literature. And we came up with this idea of designing a survey to capture Americans' trust in the healthcare system as a whole, and also in the key institutions or components that make up the system. Not just doctors and nurses, but also hospitals, health insurance companies, public providers of insurance, private providers of insurance, pharmaceutical companies, government agencies, the entire sort of spectrum of actors that contribute to forming the healthcare system. And the thinking was that it's important that not only that people have trust in the overall system, but it's also important to understand whether and to what extent people trust the individual components of the system, because It's enough for trust to be low in one of these components to undermine trust in the overall system. So we decided to sit down and design a survey to capture trust, and its correlates. And the original idea, the original plan was to administer the survey once a year for several years to track the evolution of trust over time. And so that's how the idea was born. We were very fortunate to obtain a pilot grant from the Hopkins Business of Health Initiative that allowed us to conduct the first survey in 2023. We later expanded the research team to include non-economists, and we have just recently conducted a second round of the survey. We have not looked at the data yet, but we have a second round now, and we are very, very eager to see what's going on in 2024, and we will do a third round in 2025. And hopefully we'll get more funding to do even more rounds in the future.
Very insightful. Professor, can you elaborate on the theoretical model you use to analyze the relationship between trust and healthcare seeking behavior?
Thank you for this question. And I appreciate that you have looked at the paper in detail because the model is in the paper. So the idea is this. We came up with a simple model that explains why patients choose to seek care, to go and see a doctor, okay, to seek care. In particular, we are interested in preventive care because acute, urgent type of care, often, people don't really have a choice. They have to go and see a healthcare provider. But we're mainly interested in understanding the impact of trust on preventive care, non-urgent care, elective type of care, a specific focus on annual physicals or annual checkups, and the take-up of vaccines. And so we developed this model where there's a patient who has to decide whether or not to seek care. And it's a standard economics model where the patient compares expected benefits from seeing a doctor with the expected costs of seeing the doctor, and the benefits include the expected health improvements from seeing a doctor, and the expected costs include any out-of-pocket costs, and also the any disutility experienced by the patient from seeing a physician. It's probably easiest to think about going to see a dentist. Right? We all experience disutility. I'm pretty sure that the general population tends to experience disutility from seeing a dentist. But again, the idea is this: that as a patient, I compare the expected benefit, the improvement in my health, if I do go and see the provider, with the expected costs. And a rational patient decides to do it if the expected benefit, right, exceeds the expected cost. And then we thought, okay, how does trust impact this equation? Okay, in our model, trust enters both the expected benefit and the expected cost. Trust in a provider makes a person believe that that seeing the provider will result in a higher expected benefit. And the reason is that for trust to be there, for me to trust a provider, I have to believe, number one, that the provider has the necessary knowledge, the competence to understand what's wrong with me and give me advice, recommend tests, recommend treatments that will make me better. So I need to believe that the provider has. So if I do believe that, okay, if I trust the provider, then my expected benefit from seeing that provider will be higher, which will make me more likely to go and see the provider. That's one channel. Second channel is benevolence. For me to trust the provider, I need to believe that the provider has my interest in mind when they make their recommendations. I have to believe that the provider will not want to harm me, but that they provide, but that they will want to be beneficial to me. If that's the case, then I will trust, and that will make me more likely to go and see the provider. If I don't, if I doubt the provider's motivation, and my favorite example here is, again, a dentist, okay? And I'm not talking about my dentist in particular, because I happen to trust my dentist, but the idea here is that when I go and see a dentist, and the dentist starts to recommend additional X-rays, okay, there could be a doubt in my mind. Is my dentist recommending those X-rays because he or she is concerned that there might be something wrong, and that would require an intervention, or are they just looking for additional procedures so they get reimbursed by my insurance? Okay, if I believe that my provider's motivation is just running as many procedures as they can so they can get reimbursed, even when they're not strictly necessary, see, I'm doubting their benevolence. I'm doubting their motives, and that reduces my trust, making me less likely to go and see the provider in the first place. So having trust enters the model by increasing the expected benefit. Having trust in the provider also reduces a patient's expected cost, because it reduces the disutility that a patient experiences when seeing the provider. And here, the idea is from the idea of a disutility coming from low trust is from research in public health and bioethics, and that finding that certain patients, particularly in the United States, minority patients, African Americans in particular, studies indicate that many groups of vulnerable sort of patients, they report experiencing what we economists label as disutility in the form of perception, the perception that the provider doesn't listen to them, the perception that the provider dismisses their concerns, the perception that the provider doesn't respect them fully as people, as persons. And that, again, it creates a cost, increases the cost of seeing the provider, and reduces the expected benefit too, actually, reducing trust. Okay, so that's another way in which trust or lack of trust enters a patient's mental calculation, regarding whether or not they ultimately decide to go and see a provider. So we have this model, and the model delivers the prediction that lower trust reduces the expected benefit, increases the expected cost, and therefore reduces the likelihood that a person, everything else equal, reduces the likelihood that a person decides to go and see a provider.
Your research highlights trust as a primary driver of care-seeking behavior, independent of factors like income or education. How does this reshape our understanding of healthcare access and utilization?
Thank you, Deepak, for highlighting this result from my study with Michael Darden. Indeed, even though in our paper, we are not able to manipulate trust. We don't have an exogenous shock that changes trust for survey respondents. What we do is we measure trust at a given point in time, and we examine how trust is correlated with people's decision to obtain to go for an annual checkup or an annual physical exam, and to get vaccinated against the influenza, against the flu, and to have received COVID-19 vaccination. For COVID-19 vaccination, the question is only retrospective. For the flu vaccination and for annual checkups, we ask both whether the survey respondents had received those treatments, or whether they have, they're not treatments, whether they have received gone for an annual physical, and whether they have received a flu shot last year, and also whether they plan to go for an annual physical next year and receive a flu shot next year. So we have both this retrospective and prospective self-reported healthcare seeking behaviors. And we can correlate, right, whether these behaviors are associated, right, with, we can test whether these behaviors are associated with high or low trust. Now, we find that there is a strong association. Higher trust is strongly correlated with a higher likelihood, right, of both retrospective and prospective healthcare seeking behaviors. But of course, one worries that higher trust might be correlated with access to care, particularly access to high quality care, which could be correlated with a person's level of income. If I have a higher income, I am more likely to have good health insurance, and I am more likely to have access to high quality care, and therefore I might have higher levels of trust in my healthcare provider. Similarly, there could be a correlation with education. Education is associated with a greater appreciation of the benefits of preventive care. So people with higher education could be more aware of the importance of annual physicals, of more vaccination, and that could also be correlated with the higher levels of trust. So what we do in our study is we control for education and income. And controlling for education and income, which by themselves are positively correlated with healthcare seeking behavior. Like I mentioned earlier, people with college education or more are more likely to get annual physicals, more likely to get vaccinated. Okay? People with higher income, similarly, they are more likely to seek care when, again, flu shots or COVID-19 vaccination or annual physicals. But there is a role for trust, a positive association between trust and healthcare seeking behavior, even controlling for education and income. And we think this is an important finding, which we believe we are showing this. We believe that this is a novel result. It's a contribution that we are making to the literature. This is telling us that trust has an impact on healthcare seeking behavior, even beyond access, and beyond knowledge. Because when you control for education, when we control for income, we're controlling for access and knowledge, essentially, or proxies for access and knowledge. And there is still a role for trust. So when with trust, our variable that measures trust is not simply proxying or picking up the income and education effects. It seems to be playing a role that is separate from access and from education. So there is really, so the message there is that we really should care about trust, because it seems to be playing a role that is independent of other factors that previous research and our research confirms, actually, that those other factors are playing a role in predicting healthcare seeking behavior.
You found that trust in doctors, nurses, and hospitals impacts care seeking behavior, but trust in insurers does not. So, what do these findings reveal about the different roles these sectors play in shaping public trust?
Yeah, thanks for this question. It's really, yeah, we found that there are big differences in Americans' level of trust in the various components of the healthcare system. People have placed a lot of trust in providers, doctors, and nurses in particular. Nurses are the most trusted category of healthcare providers in the United States, followed by doctors. Hospitals also tend to be trusted. Other categories of other components of the healthcare system do not enjoy such high trust. In particular, the two components of the healthcare system that are least trusted are private health insurance companies and pharmaceutical companies. Those don't enjoy a high level of trust. The opposite is true. They are not trusted by the American public. And I should have mentioned that what we have is a representative sample of the American population. So the survey is representative. And this is concerning. It's concerning because insurance companies, pharmaceutical companies are important components of the healthcare system. Insurance companies provide coverage for patients who undergo clinical medical procedures. Pharmaceutical companies come up with new drugs, vaccines, and so if people don't trust them, it's a problem. Trust in the overall system can be compromised. Our survey includes an open-ended question where we ask respondents, what were you thinking? What were your main considerations? When you answer the question about trust that we asked previously. And when we look at the answers, they are very informative because, for example, when it comes to pharmaceutical companies and health insurance companies, a concern that we hear from respondents is the perception that these companies are not not always acting in the best interest of patients. There's the perception that those companies' main motivation is making money. And so they're perceived as looking for ways to cut costs and improve their revenues, as opposed to being motivated by doing what's right for their customers, who are patients. And that perception erodes trust. And we do see that in the data. Now, you asked a specific question, why is trust in health insurance companies not strongly correlated with healthcare seeking behavior? And the honest answer is that we're still looking into that. Most of the action seems to be in our first survey. It seems to be seems to relate to people's trust in providers. With one exception, and perhaps we can talk about this later. One exception is represented by trust in some government agencies. That is correlated with certain types of healthcare seeking behavior. But there are some, I think there are some results from our first study where we have some clear answers or clear, we have our interpretation of what we think is going on. For other questions, we need to do more work.
Professor, how might policy interventions target trust in healthcare providers versus insurance to improve healthcare utilization?
Oh, the insurers, I think my view is that, and this is just my opinion, my view is that health insurance companies need to address the low trust situation in which they find themselves. They need to do it in ways that are visible, credible, and meaningful. There are some data which I have not collected personally, but I have seen data from private health insurance companies regarding claims that are denied, and the rates of the claim denial seems to be particularly high. And now there could be valid reasons why some claims are denied, but I suspect that some insurance companies might be denying too many claims, even when there are valid medical reasons for the patients to be requesting coverage of medical procedures, tests, and so on. And so I think more transparency would be more transparency, right? More transparency in terms of what is what are the rules that are behind, whether a claim is denied or not, would be very much welcome. But looking at our results, the low level of trust of Americans in pharmaceutical companies and health insurance companies, private insurance companies, trust in Medicare and Medicaid is higher, which is interesting. It's trust in private health insurance companies that is low. That needs to be addressed. An industry, it is not sustainable. In every industry, it's very well understood that if I'm buying something from a seller, it's very well understood that the seller is making money. It's fine, it's fine. And whenever I buy something at a given price, what's happening is that I am willing to pay that price because the benefit that I'm obtaining from paying the price and obtaining the good or the service is higher than the price that I'm paying. So I derive utility, or what we call a surplus, a consumer surplus in economics. And it's well understood that the price that I pay is above the cost incurred that the seller incurs to produce and distribute the goods. So the seller is making a profit, is making money. That's well understood, and usually that's not problematic. Okay, in this case, it is problematic because the patients are unhappy. They are buying something, they're paying their insurance premiums, and when they get sick, their expectation is that their claims will be covered if if their claims are related due to valid medical reasons. This is not happening all the time. It's destroying trust. Something needs to be done about this situation, because an industry cannot. This is not sustainable from even from the industry's own point of view, in my opinion.
Your findings indicate no differential relationship between trust and care-seeking behavior among Black respondents, but show variations by age and political affiliation. What might explain these demographics differences, and how should they inform policy design?
Yeah, yes, that's right. We were somewhat surprised by the first finding, the finding that whites and blacks in the US show a similar relationship between trust and healthcare seeking behavior. This means that for both groups, higher trust is robustly, strongly associated with higher healthcare utilization, but there is no differential relationships, which surprised us a little bit because of this prior evidence that the African Americans are more distrustful of the healthcare system. So regarding that result, we plan to just look into it some more in future surveys. So that's the state of our work on that. This is a finding that we have from the 2023 survey. It seems to be sort of it is what we find in the data. We'll collect more data in the future to explore more and maybe get a better sense of why we find this result. Regarding the other groups, we do find that older Americans are more trusting of the healthcare system. And our interpretation is that older Americans who are older than 65, they have access to Medicare, and they're happy with Medicare. And this creates trust. So that's our current explanation for that. Regarding political orientation, this is a result that intrigued us a great deal. We are in fact working on a second paper, which is work in progress right now, but I can give you a preview. We find that the key finding seems to be that Democrats and Republicans have similar levels of trust, or actually Republicans seem to have a slightly lower level of trust in the US healthcare system as a whole. Most of it is coming from trust in government agencies that have to do with health, in particular with the Center for Disease Control, with the CDC. So we're exploring that. The gap when it comes to trust in the CDC, the gap between survey respondents who identify themselves politically with the Democrats and survey respondents who identify as Republicans is big, with Republicans showing very low levels of trust in the CDC and Democrats showing a very high level of trust in the CDC. And this gap explains a good share of the gap in people in respondents' propensity to have received the COVID vaccine and also to be vaccinated for the flu. So this gap seems to be having an effect on behavior. And this is what we are seeing in the data, and we are currently analyzing those data to get a better sense of what is going on, and we plan to use these results in a separate paper.
Professor, given the declining trust in medical and scientific expertise, what strategies can policymakers or healthcare leaders implement to rebuild and sustain trust in the healthcare system?
Yeah, really, really good question. Really important question, Deepak. So my view is that particularly for public agencies, particularly for public agencies, there seems to be a perception that they are politically motivated because they are run by individuals who were appointed to those positions by the executive, by the president. And there's a perception that we see in the data, particularly for the CDC, like I was mentioning earlier, that the agency is acting in a way that is motivated politically as opposed to being acting in the interest of American patients. And this may or may not be correct, but it is a perception that appears to be impacting people's behavior. And we should be concerned about that. So one idea or one step could be in correcting this perception by maybe modifying the process through which the heads of these agencies are appointed, to remove the perception that they are appointed politically and create the perception that the leadership of these agencies is decided or is assigned to competent individuals who are not pushing a political agenda, but who have the interests of the American public in mind, and only that in mind. So depoliticizing certain positions. Now, this is an idea. How to do it, it's a longer conversation, a more complicated conversation, but I think that something along those lines needs to happen.
Professor, how does trust interact with other factors such as political polarization or misinformation, particularly in contexts like vaccinations and pandemic response?
Yeah, this is related to, I think, the finding that I was mentioning earlier, that Republicans have low trust in the CDC and therefore, as a result, are less likely to perceive the COVID vaccine as helpful, and they also are less likely to plan to get a flu shot. The perception that certain recommendations are not due to medical reasons or scientific reasons, but to political agendas, that perception appears to be real. I don't mean that the substance of it is necessarily real. I mean, the recommendations could be perfectly valid medically, but the perception is there that they're not. The perception is there that the recommendations follow a political agenda. So yes, there's definitely a problem there, and I think we need to do something to remove the political factor, the ideological political factors from those types of recommendation, and that would require depoliticizing the agencies somehow. But again, easy to say. How to do this is not straightforward. It would require discussion, conversations, and sort of actual proposals for how to do this.
Professor, my last question. What are the next steps in your research? And how do you envision the role of trust evolving in future healthcare systems?
Thanks for asking these questions. So when my co-author Michael Darden and I present this work, we find we find a lot of interest. We find a lot of interest, and we have received a lot of suggestions for how to continue this research agenda. So, for example, I presented this work in Italy and in the Netherlands, and I am starting, Michael and I are starting collaborations to repeat the survey in those countries, of course, adapting the questionnaire to the context of those countries are very different. Both countries, Italy and the Netherlands, have very different healthcare systems compared to the US, but still, trust appears to be an important factor there as well. Another direction, so one direction is to expand this research internationally. Another direction is to understand the impact that technological advances might be having or might have in the future on trust, particularly the growing role of artificial intelligence in medicine and in the clinical sphere more broadly. These are largely like, how does AI impact patient trust when it becomes a tool that is used by healthcare providers to diagnose and make recommendations and so on. It's possible that AI increases trust in the system if it creates the perception that the system is using, cutting edge technology to make better decisions. But it could also decrease trust among certain patients if it creates the perception that now, a machine is making decisions instead of your trusted, family physician. And so this is a very, I think, intriguing set of questions that we plan to explore going forward, and which, 2 or 3 years from now could be the subject of another conversation with you in your podcast, Deepak.
Thank you, Professor Mario Macis, for sharing your invaluable insights on the role of trust in healthcare seeking behavior. Your research highlights critical aspects of how trust influences healthcare utilization, shaping both individual decisions and broader policy considerations. To our listeners, thank you for tuning in. We hope this conversation inspire you to reflect on the importance of trust in shaping equitable and effective healthcare systems. Stay connected for more insightful episodes ahead. Until next time, take care and keep exploring. Thank you, Professor
Thank
Mario
you.
Macis.
Thank you, Deepak. It was an honor to be part of your program.